In this presentation, we will be talking about SPECT in terms of its radiation protection, safeguarding patients and healthcare professionals. Here are our reporters. What can you expect in our report is difference between SPECT and PET, disposal of radioactive materials, post-procedural patient management, and lastly, room design and dimension for SPECT. Let us first discuss what is nuclear medicine. So nuclear medicine is a branch of medicine that evaluates body functioning and diagnoses and treats illnesses using radioactive tracers, often known as radiopharmaceuticals. The imaging methods used in diagnostic nuclear medicine are mostly dependent on measuring cellular physiology and function. There are many modalities or subspecialties under nuclear medicine. There are two most common 3D techniques by nuclear imaging: single photon emission computed tomography or SPECT and the positron emission tomography or PET. Both are non-invasive diagnostic modalities that are able to provide valuable metabolic and physiologic information about many pathophysiologic and functional disorders. A remarkable feature of SPECT and PET is their ability to improve contrast resolution manifold compared to planar scintigraphic imaging. The two imaging modalities have proved useful as applications in molecular imaging research and translational medicine. In addition, attempts to derive quantitative parameters are more accurate than planar imaging. Furthermore, when timing factor is added to 3D imaging, the amount of information that can be obtained from analyzing the data is significantly high. Two examples are worth mentioning: when SPECT or PET is used to collect tracer spatial distribution and its associated temporal component. One of these is gated myocardial perfusion tomographic imaging, in which the tracer distribution and heart function can be captured in one imaging session, providing an assessment of myocardial perfusion parameters such as defect extent and severity or tissue viability, in addition to the calculation of regional and global ventricular function and ejection fraction. Another important area of application is the study of tracer distribution during the time of course of tracer uptake and clearance from biological tissues. In these acquisition protocols, dynamic frames are collected over predefined timing intervals to record tracer flow, extraction, retention, and clearance from the tissue of interest. And now let us move on to SPECT and PET similarities and differences. SPECT imaging relies on the emission of single photon emitters such as technetium-99, iodine-123, indium-111, gallium-67, and so on. On the other hand, PET imaging uses positron emitters such as fluorine-18, carbon-11, oxygen-15, and nitrogen-13, either labeled or unlabeled to other compounds as in some SPECT diagnostic compounds. For example, the most commonly used single photon and positron emitters are technetium-99 and fluorine-18. Respectively, both can be labeled with many compounds to target a particular physiologic and biochemical disorder. When compared with PET compounds, SPECT tracers are widespread and commercially available from many vendors, in addition to their long-term use in clinical experience. Most PET tracers necessitate an on-site cyclotron specially for short-lived positron emitters, thus, cost is relatively higher. And now let us move on to SPECT versus PET disadvantage. SPECT imaging has lower resolution and sensitivity. The use of collimator results in tremendous decrease in detection efficiency as compared with PET. Spatial resolution in SPECT deteriorates from edge toward the center. PET is relatively constant across the transaxial images, best at center. Attenuation severe in SPECT, but accurate attenuation correction is possible in PET. SPECT versus PET advantages. SPECT is less expensive than PET to build and maintain. SPECT is non-invasive while PET scan require arterial sampling, which is invasive. Listed here are the summary of SPECT versus PET in terms of its costs, availability, spatial resolution, temporal resolution, sensitivity, signal-to-noise ratio, and variety of ligands. And now let us move on to management of radioactive waste. Radioactive waste is generated as a result of handling unsealed sources in the laboratory. Leftover radioactive material from routine preparations, dose dispensing to patients, contaminated items in routine use, and so on. The waste arises in a large variety of forms depending on the physical, physiochemical, and biological properties of the material. In radionuclidic therapy, the waste may also consist of excreta. And now let us move on to storage of radioactive waste. The solid waste generated in working areas should be collected in polythene bags and transferred to the suitable containers in the storage room. The liquid waste has to be collected in either glass or preferably plastic containers. The waste containing short-lived and long-lived radionuclides should be collected in separate bags and stored in separate containers. This will avoid unnecessary exposure to the staff handling the radioactive waste. The storage room should have proper ventilation and exhaust system. The shielding around the waste storage room should be adequate to prevent any leakage of radiation. The waste must be stored for at least 10 half-lives for decay or until such time disposal is conveniently possible. Disposal of solid waste. Low-activity waste is solid waste comprised of paper tissues, swabs, glassware, and similar materials that are of low activity can be disposed with ordinary refuse provided no single item contains concentrated activity, and they do not contain alpha or beta emitters or radionuclides with a long half-life. The waste does not go a recycling procedure, and the radionuclide labels are intact. High-activity waste, contaminated clothing, and those items that are needed to be refused are segregated and stored for physical decay of radioactivity or decontaminated separately. Incineration of refuse containing non-volatile radionuclide concentrates the activity in the ash. If the ash contains undesirable high activity, special disposal methods should be adopted. The ash can be diluted and disposed without exceeding the specified limits or buried. And now for the disposal of liquid waste. While disposal of liquid waste through the sanitary sewage system, the limits of dilution and disposal should not exceed the prescribed limits recommended by the competent authority. Lastly, disposal of gaseous waste. Gaseous waste originate from exhaust of source, fume cupboards and wards, and emission from incinerators. Points of release into the atmosphere should be carefully checked, and filters, including the charcoal, may be used wherever possible. The concentrations of radioactive material in the air leaving the ventilation system should not exceed the maximum permissible concentrations for breathing unless regular and adequate monitoring or environmental surveys are carried out to prove the inadequacy of the disposal system. When large quantities of radionuclides are routinely discharged to the environment, it is advisable to make environmental surveys in the vicinity since many radionuclides will be concentrated on the surfaces.
Post-procedural patient management. Specific instruction to the patient. It is the combined responsibility of the physician and the medical physicist or technologist to administer the desired dose to the patient. The patient is normally advised to come with an empty stomach or after a light breakfast and not to eat or drink anything for 12 hours after therapeutic administration. They are also advised to void the urinary bladder frequently and to flush the toilet twice after each voiding. This practice is not only reduces the radiation dose to the kidneys, bladder, and the entire body of the patients, but also help in their fast release from the hospital. Discharge of the patient from the hospital. The regulatory authority of each country decides the maximum limit of activity of I-131 at which the patient may be discharged from the hospital. This can be roughly estimated by measuring the exposure rate from the patient at a 1 meter distance with a calibrated survey meter, which should read approximately 50 millisievert per hour or 5 millirentgen per hour for a body burden of 30 millicurie or less. Post-treatment. The patient must be provided with an instruction card detailing the type of duration and any radiation protection restrictions that must be followed at home. In female patients of reproductive age, two important aspects need to be considered. First is the possibility of pregnancy. Radionuclide therapy is strictly prohibited during pregnancy. Pregnancy after radionuclide therapy should be avoided for at least 4 months, or as advised by the treating physician. Room design and dimension for SPECT scan. SPECT imaging room. A SPECT or single photon emission computed tomography imaging room is a dedicated space within a medical facility specifically designed for performing SPECT scans. It is a controlled environment that ensures the safety and proper functioning of the SPECT scanner and provides a comfortable and efficient experience for patients and medical staff. SPECT control room. An adjoining control room allows technologists or radiologists to operate and monitor the SPECT scanner from a safe distance. The control room is equipped with consoles, monitors, and a computer system to control the scanner, capture images, and communicate with the patient if necessary. Layout and space. Room should have a sufficient space to accommodate the SPECT scanner, patient bed or chair, and any additional equipment required for the image procedure. The layout should be designed for easy access to patients and optimal positioning for scanning. A SPECT system, it looks like a CT or MRI system, but the hardware is different. This is the room design and dimension of the SPECT system. Equipment space. This refers to the area required to accommodate the SPECT imaging equipment, including the gantry, the rotating arm that houses the detectors, and the detector system. So, safety consideration. Safety is a paramount in SPECT room design. Adequate space should be allocated for emergency exits and fire safety measures. Additionally, radiation shielding should be incorporated into the room to protect both patients and staff from unnecessary exposure to radiation. Workflow efficiency. Efficiency workflow is essential for smooth operation and timely imaging. Design the room to allow healthcare professionals easy movement within the space, ensuring quick access to necessary equipment for efficient scanning and patient management. Control room space. A separate control room adjacent to the SPECT imaging room is typically needed. This control room houses the technologist who monitors and controls the SPECT system during the scan. Electrical and HVAC requirements. SPECT systems have a specific electrical power and ventilation requirements. It is important to consider these requirements to ensure proper functioning of the equipment. This may involve adequate power supply, electrical grounding, and ventilation systems to maintain an optimal environment for SPECT imaging.